Dr. Sarika Persaud is a psychologist and coordinator of diversity, inclusion, and social justice initiatives at Fordham University. She is an adjunct professor at CUNY, John Jay. Dr. Persaud is certified in QPR, which is a gatekeeper suicide prevention training, and has led culturally adapted trainings in suicide prevention for teachers, social workers, community organizers, and members of nonprofit and government organizations in the South Asian and Indo-Caribbean community in New York City. Her research focuses on developing a culturally adapted mental health programming for Indo-Caribbean youth. Specifically, her research investigates school-based suicide prevention services for youth in Guyana. She has also published papers on work here done in Guyana in collaboration with the Ministry of Education, and we are so thrilled that she'll be presenting with us today. Thank you, Dr. Persaud.
Yeah, thank you so much. It's really nice to see, well, I can't see all of you, but I can see some of your names, which is fine. I'm going to just share my screen now so you can see my presentation. All right. So, all right. So I'm going to present mostly on my research that I have conducted in Guyana about suicide prevention with youth, but I want to say that it's all very preliminary, meaning that, you know, when I'll talk more about the groups that I've done this research with and collected data from, but, you know, I've only been able to work with one school so far in one area of Guyana. I really hope to expand more to different parts of the Guyanese population, more of the Caribbean, and even more of the diaspora here in New York. But I really hope the information that I present, it's preliminary, but it's a starting point for us to branch off and learn more and think about what questions we can start to ask next. I guess before I begin, I also wanted to say a couple more things about myself, which is that I'm a psychologist. And the way I look at some of these questions, even though I've been trained like a scientist in doing, you know, different types of experiments and something closer to medical research, psychology, came from the combination of medicine and philosophy. So I'm somebody who's always asking why, and wanting to make meaning of things and understanding about, you know, okay, we might have some data in front of us, but does it match our reality and match how people feel in reality? So I hope that, you know, that is communicated to all of you as I share the information that, you know, yes, it's good for us to know this information. It's good for us to know the research, but it's also very important for us to use that to reflect on our own lives and how we work with the people that we're really trying to serve and to help. I also did this research along with Dr. Prerna Arora, who is at Columbia University. And so I guess I also just wanted to give a heads up that a lot of the work that I do is with the broader South Asian community here in New York City. So that's why the preliminary focus is on Indo-Caribbean people. But, you know, I really would I think we need to be as inclusive as possible with people of all different races, religions, ethnicities, genders in the Caribbean. Okay, so some of the research that we've done here at this study has to do with identifying perceived risk factors and perceived causes of suicidality and of severe mental health issues. So to go over some of the areas of overlap between risk factors across US, Canada, Europe, Australia, the Global South, and Guyana. So most of the research we have has been conducted in the Global North, which is US, Canada, Europe, Australia. Previously colonizer countries, and some still conducting colonization projects. And also there are countries that have, you know, they're quite well resourced in terms of the research they're able to conduct. So we know a lot more about risk factors for suicide in these countries. And that could include things like, you know, parental pressure on youth, access to means. So what that might look like in the US is access to guns, but in Guyana, that might look more like access to pesticides. Some of these things you might know about. And in the Global North, we have much more understanding of Okay, causes of suicide might also include being excluded by peers. So I'm talking more about youth risk factors, feeling a sense of a lack of social connection. And there's a little nuance there, which is, it doesn't mean that a young person doesn't have a lot of friends, or they have a lot of friends and therefore it's a good thing. It's how supported you actually feel by these people. Do you actually have somebody that you could go to and speak to about your problems? Do you have people that you feel like you can trust? So, someone might have a lot of friends, but that doesn't mean that they trust all those people, or they feel safe with emotionally safe with all of those people. So that's a very important part. And we also know that having some support and being able to actually talk about mental health and talk about suicide is a supportive factor, is a protective factor. So we know all of that from our research done in the global north. The global south, we have less information about, but there is information out there. More risk factors that are from the global south have to do with intergenerational trauma, a history of colonization in the country, types of codependent family structures. And what I mean by that is families in which an individual always feels like they have to deprioritize themselves for the good of the family. So a certain level of that is okay, right? We come from a beautiful collective culture, collectivist culture. And what that means is you can depend on people. If I know that, I'm coming home late from work one day, it's very easy for me to identify a neighbor in the neighborhood or a family member who I trust, who I can say, could you please just watch my child for an hour or two? In America, a lot of people don't have that. A lot of people they can't trust their community, or they feel like they can't trust their community members. And it's a sad thing. Like, there's a sense of people being very isolated. So in a lot of countries in the global south, whether those are countries in Latin America, in South Asia, what have you, there is a lot more of this community, a lot of more community support. On the other hand, what that can mean is a lot of people don't necessarily have a conception of what privacy is, of what a private life is, of what it means to, have things that you'd rather not share with other people, or that you're not ready to share with people yet. Or, there's this problem of gossip. So sometimes that can lead to what's called codependent relationships, which are relationships in which you feel like your entire identity is bound to what you're doing for another person, but you're not quite seen for who you are. Like, deep down on all of the different sides of yourself, you're not really quite seen for who you are. I mean, codependent relationships you can be in America and have it too, but it's more of a problem in collectivist cultures. And then specifically for Guyana, I'm sure as you've attended other presentations in this conference, there's not so much research that's been conducted specifically in Guyana, but from what we can tell is that for youth especially, bullying is a problem, especially on the basis of gendered bullying and about sexuality. Someone's sexual orientation. Another problem is lack of resources. So lack of access to care, lack of access to mental health care, and lack of access to being able to identify people who might be at risk. But, hopefully this study and what I will share about what I found will add to that research pool that we have. Additional barriers that exist in the global south, there will be a lot of countries where it's illegal to die by suicide. So actually thinking about suicide or admitting to somebody that you're thinking about suicide could cause problems for you legally. So people don't want to talk about it because they don't want to get in trouble with the law. There are views of suicide as cowardly or immoral. There are people who believe that suicidal ideation is something that is shameful. So they don't really want to talk about it. It's you can get blamed for that. And it's not something that you should seek support about, because you should be ashamed of yourself for thinking that way. And then, of course, there are some systemic limitations that come from being in post-colonial society. So a lot of countries are still grappling with the effects of basically having all of their resources, their natural resources, people all these things ravaged by capitalist interests. And we're still recovering from that. It's really not quite been that long. And Guyana specifically is one of those countries where there still has been some level of political instability and interpersonal instability that people are coping with because of the trauma of colonialism. Okay. Oh, oops. So one of the ways, there's many ways that have been presented in the research, but I'm going to focus more on one of the ways we can reach youth is on school-based mental health services. So there's a ton of research that shows us if we can reach youth in schools, it's a great way to actually help people. So first of all, it provides accessible care in under-resourced areas, especially if you think about Guyana. Not every village has a clinic, not every village has a hospital, but pretty much within walking distance for everyone, or some commutable distance, there's a school, and every young person pretty much is going to school. So it's accessible in that, there are a lot of schools around. And a lot of research has shown that it's very effective in reducing mental health symptoms if we can reach young people in schools, and it kind of integrate it into even their curriculum and how teachers talk to students. Here are some examples of school-based mental health interventions: signs of suicide, YAM, QPR, which is the one I use for my study, and sources of strength, which is also called SOS. You can look those up and you'll see kind of what the programming is like. You can try them out with your groups of young people, but I'll tell you about what we've done with QPR. So the purpose of the study was to better understand barriers to mental health help seeking. So what is it that keeps people from seeking help, even if they know they need help? To add to the research on cultural fit for evidence-based suicide prevention and intervention programs in the Global South. So as I said, most of these interventions and most of the research has been done in the US and Europe. So while we have some, idea that yes, these things that we train people in for suicide prevention will likely be helpful for people no matter where you are in the world, there have to be some adjustments made because there are cultural differences that exist, whether that's in how youth relate to adults or not. One big difference I remember is that there's a lot more formality in, at least compared to America or New York, there's a lot more formality in the way that young people, like students, communicate with adults in schools in Guyana. There's, yes, ma'am, yes, miss, all of that. Yes, yes, sir. And it's not necessarily a bad thing. It's just a difference, right? Where in America, it's maybe not a good thing, but maybe sometimes you call your teacher Miss whatever, but Miss Smith or whatever it is. But there's definitely not as much formality. It can feel like sometimes teachers toe the line between being your parent or your teacher. So in some ways it's easier to approach teachers. In other ways, it can blur some lines there, I think, psychologically for both teachers and students, where some teachers can overlook certain students the way that a parent might sort of assume with the child, oh, that child is the strong one, they're the smart one, they'll have things figured out. So there's positives and negatives to both, but essentially there are cultural differences, what I'm trying to say. Some of the point of this research was to elicit input on recommendations for suicide prevention. So we want to know what the community thinks would be helpful, and to be able to improve utilization and outcomes, especially for people from historically disadvantaged backgrounds. So the way we did this study was, there's kind of two different steps. Well, there's many different steps, but two main studies were done. One was a needs assessment, where we gathered data on what are the needs of the community and actually how can we use that to prepare the intervention. And then the second was actually implementing the intervention. So in the needs assessment, we had 16 adults and 40 students. And then we had 3 adult focus groups and 40 one-on-one student interviews. In terms of how the intervention was done, so we used this to prepare a teacher training in suicide prevention. So when we actually implemented that intervention with the teachers, there were, I believe it was about 21 teachers that were actually involved in the training itself, but I'm presenting more on the risk factors and the information we gathered from the needs assessment right now. I'd be happy to answer more questions about the intervention later though. And so for the measures, we use semi-structured interviews. So it was, qualitative study and a short demographic questionnaire. So in terms of the procedure, so the first thing we did is we started by discussing concerns with the school principal. So this was done at a private secondary school in Guyana, and I was able to get in touch with the headmaster and be able to speak to that person about what are concerns with youth mental health in your school, what needs to be addressed. I didn't want to assume it was suicide, right? Maybe it's something else. Maybe there's another problem there. But yes, they identified it as suicide. And so then we were able to develop some flyers and information sessions with participants. We actually went to Guyana and were able to answer people's questions about the study and what actually would be involved in research. It's a very weird thing to have people fill out questionnaires. I don't think most people are involved, in research day to day. I'm an academic, I'm in a university, and so I'm very familiar with the research process, but for normal people, it's very strange to have to answer these questions for someone who you don't really know that well. So kind of debriefing people on the process of research as well and making them comfortable with it was a big part of it, the process. And then we actually conducted the interviews and the focus groups. So that's where we actually spoke to people and gathered this information. So I'll share some examples of that. And then we used a grounded theory approach to analyze the data. So basically, we had all of these transcripts. We had to listen to the recordings, transcribe all of the interviews and the focus groups. And then there's a process called grounded theory coding, where you can start to isolate parts of transcripts and be able to sort them into themes and organize your data that way. So I'll be able to share some of those themes with you today. And then after that, we took those themes and wrote it in not so academic language, in language that anyone can really understand, and we shared it with the school. So we were able to speak to the headmaster and say, listen, this is what we found. This is what we think would be helpful specifically for your school. And here's what you could do to implement it. And at that point, it's up to them kind of if they want to take our advice or not, but we still offer our support and an ongoing relationship, because I think it's very important that as researchers, we don't just go into communities, gather information and leave. That can make people feel kind of like a laboratory subject. It doesn't feel very good. We want to actually feel genuinely connected to people and we really care about them, because we do. We do care about them. So we made sure we keep up we still have a pretty good relationship with the people at the school. So just to go over kind of what was on the interview, we asked about whether suicide is a problem in their community, if they believe it is or not, causes of suicidality among adolescents, protective and risk factors. We asked about help-seeking behaviors, the school's role so far in suicide prevention, and the school's needs, what still needs to be done. So the first major area that we identified as a cause or a risk factor, in this case, it was more identified as a cause for suicide, was shame and stigma. So the first area was a fear of being perceived as weak, crazy, immature, or stupid. So like one student says, you see, when people, especially in the Caribbean, when they hear suicide, they think weakness right away. Like if you say you're mentally ill, they think, oh, you're a crazy person, go away from me. If you say you're suicidal, people will just look at you in a different way. I want to share that a lot of the students in this study, even though we were not asking them specifically, have you thought about suicide? They did. A lot of them chose to share with us that they did. So some of these students are actually talking from personal experience. Also, it really kind of is poignant that this is such a young person, and at a young age, they already understand that people will call them crazy if they talk about their mental health. The second was a fear of being judged, shamed, or mocked for having suicidal ideation. So the interviewer asked, why don't you think some people ask for help for suicide? And the student said, well, because they might be made fun of. As I said, in Guyana, people don't think of suicide as that serious. So if they come out, they're not really sure of how the person will react, if the person's going to take them seriously, if a person's going to brush them off. And it's very unlikely that they're going to get help unless if they go to the right person. So right away, there's this sense that there's the right people to talk to and there's the wrong people. And not every adult is going to be open to listening to me. And it's very sad to think about, because we tell young people, just go to an adult and talk to them. But not all adults are really willing to hear. So people in this room are adults, and we know other adults, our friends and our family members are adults. So it's really up to us to be able to change the perspectives of our peers and be able to help them understand that when a young person comes to you, or anyone comes to you to talk about how they feel, telling them that it's not that serious is very invalidating. You might think it's supportive because you're telling someone, oh, don't worry about it, get it off of your mind. But to that person in that moment, it really matters a lot. And we do have to let people understand, we understand the seriousness of what they're sharing, and we hold it with a lot of respect. Another is this fear of being gossiped about for seeking help. So this person says some people will be afraid to speak because they're afraid of, okay, like if I share my problems with her, she will go and tell somebody else, and then it will circulate and everyone will know my problem. So I guess that's one of the reasons someone won't really share their problems, because of the stigma and lack of confidentiality. Well, you know, one thing we hope to help young people understand is if you speak to a mental health professional, we do have certain, you know, rules about confidentiality. But when it comes to, you know, the first step, a young person's not going to go directly to a doctor. They're going to go to their friends or to another adult. And there is this fear of gossip that is, you know, young people are not making it up. We know gossip is a problem. we know gossip is a problem in our communities. We don't have to pretend like it isn't. And we have to understand, I think, a little bit of where it came from, which is that, you know, if we think about times, earlier times, you know, in sort of colonial era, people did not have Twitter. They did not have phones. So to share, and even attempts at either people who were slaves or people who were indentured laborers, their attempts at making some sort of media, like a gazette or a newspaper, were often, you know, ended by the British or other, you know, colonizing powers. So people couldn't really share information openly. And the way they had to do that and to keep each other safe was through telling person to person, you know, like saying, oh, did you hear what happened? This person, you know, that guy over there did this thing and then he got, you know, hurt for it. So these people spread information that way from person to person. And it's also a way for people to keep each other safe. So especially if we think about women, you know, a woman might be able to tell another woman secretly, hey, I can't say this in front of men because I'm scared of getting hurt. But that man over there, you know, they wouldn't say the word sexually harassed, maybe in colonial times, but they would say, you know, he did something to hurt me or to make me very uncomfortable. And from the outside, that can look like secret sharing or gossip, or could look like you're kind of maligning people. But really, it was our way of like sharing information in our communities. So it's not always a bad thing. The problem is when it becomes a way to shame people and it becomes a way to judge young people. So when you're not sharing information to keep people safe, but to make people feel worse, or to kind of push people into submission so that they act in a certain way that your community will approve of, that's not good. So I guess how helping young people understand, like, you know, what is gossip, what is not gossip, like, you know, telling an adult, my friend is thinking about suicide is not gossip. You're not ratting your friend out or anything like that. The second major area was negative parental responses. So there's this fear of invalidation or blame from parents. And invalidation, like I said before, is referring to you'll share something and it's taken as like not really that serious, or maybe even not true. So this young person says, when I speak to my mom, she'll think like, why would someone want to cut themselves, damage their skin? Why would they want to kill themselves? That's a stupid idea, right? she would say that they killed themselves. That's something they did wrong. I would tell her, people who are that depressed kill themselves. We have a neighbor who used to cut herself. My mom, when she saw it, she said, yeah, she used to cut herself. That was a stupid thing to do. And the lady was like, yeah, that was a stupid thing to do. So this is a young person who may have been thinking about sharing, their self-harm with their parents, but unfortunately, because the parent had talked about it in a way that was like shaming or blaming other people, rather than having compassion, rather than saying something like, wow, that young girl must have been going through something really difficult. I hope she got the support she needed. Or rather than saying something like, okay, like school seems to be putting a lot of pressure on these young people. Maybe there's something we can do to help them. Instead of speaking about it in that way, this young person has already understood that there's a lot of shame connected with being depressed. They don't understand it as sort of a natural part of the human condition. We all get depressed sometimes. We all need help. The second was physical abuse or being punished for disclosing suicidal ideation. So young people talking about, it's an option to talk to someone at home, but they might not feel comfortable telling someone because they might be afraid that they might get yelled at, they might get licks by their parents or someone at home. So being punished for talking about their feelings is, it's a sure way of making sure a young person doesn't ever talk about their feelings. The third major area was awareness of and beliefs about mental health services. So there's this belief of a lack of publicity and limited awareness about available mental health services. An adult shared that I've looked into it and there are more places that offer help now, more for youth than to adults, but I don't think they're publicized as much. I know of it offhand, but you see, there's this thing in this country. These things are publicized in newspapers, but very few people in Guyana are newspaper readers. So there needs to be more publicity in accessible ways. The costs associated, these people are saying, I think it's also the cost attached to seeing a mental health provider. For some persons, it's pretty expensive. So some people might not have the ability, right? So that's the other thing. Some people might not be able to afford to pay to see the one known psychiatrist that we have. $5,000, which is in US dollars is $24, is his private consultation. I don't know if that's still the case, but at the time of this study it was. I think he works at the public hospital and there's a certain period of time during the day that he's there and then he leaves and goes to a private clinic. So for some people, because of the lack of resources and the cost, it's hard to make it accessible. There were some negative beliefs about mental health workers and mistrust of the intentions of mental health workers. They told me a lot of these sort of like urban legends about doctors and what doctors do. So this person says, I heard this one story that a doctor falsely diagnosed a patient with a mental illness so that the patient had to continue taking pills. So many tricks they do to get money, power, and all of these things. So basically the doctor still wanted money from the patient. So they told the patient, yes, you still have this mental illness, and was selling them some type of like fake pills or something. That's something the government hopefully could regulate. I don't really know the process for that, but that's really unethical. And then some recommendations. So they were in these three areas. So including some level of religion and spirituality in interventions, a lot of people said they would like that. Not everyone connects with religion, not everyone connects with spirituality, but the way they had been speaking about it, they said, those are things that are important in the lives of many Guyanese people and Caribbean people in general, no matter what your religion is. So being able to, reach people who are in religious institutions could also be helpful. And then trainings for parents. So as I've spoken about here, a lot of the damage that can be done can be caused by adults in the lives of children. A child is not born having shame about their feelings. They're taught to have shame about their feelings. So if we can educate parents in just a different way to do things. I'm not saying that all parents are wrong or all parents are bad or anything like that, but most people who become parents, the way they learn how to be parents is by observing their own parents. So it's kind of like, if you're training to be a doctor and you've only read one textbook, hopefully that textbook does have a lot of good information, but there's so much more research out there. There's so many more people to speak to. There's many professors, and if you're only basing it on one thing, that's really limiting your ability to parent your child. So there could be some trainings that we involve parents in. That's another, research has shown is a very effective way to increase youth mental health outcomes. The second were the recommendations we got in terms of school-based interventions. So increasing opportunities for students to communicate about their mental health. I remember some young people in the study were talking about, there's this time in the year where we have a little more like recreation time, like we're doing yoga, we're doing sports, and during that sort of free time is when we have a chance to sit around, to just talk to each other, to talk about our worries, about our problems, about things we're excited about with our peers. And then so these things come out, these things naturally, if someone is struggling with their mental health, that's the time when they're able to tell their friends. So while it's important to have structure in our schools, of course, and to make sure, students are meeting sort of academic standards, on the other hand, they need to be able to develop relationships as well. That's what's going to keep them emotionally healthy. So yes, we can alleviate stress through extracurriculars. We can have people have an opportunity to explore who they are and what they like, who they are as a person, and what makes life, enjoyable. There's that really famous quote that, doctors, engineers, and lawyers make it possible for us to live in society, but it's the arts and dance and poetry and music that make life worth living. So we need to give young people a chance to explore those things, because that's what gives life purpose. It's love and connection and art. There were some mixed views on school counselors. Some found them accessible. Like they said, it would be really great if we had a counselor in the school, because then we can just easily go speak to them. But at the same time, there were questions about the confidentiality still. So that would have to be communicated to young people. And there were a lot of support for a stakeholder training, which is why we ended up conducting one. So we did have a training where, I'd have to present on it another time, not this time. No, I don't have that much time left. But we did a training where we trained all of the teachers in the school on suicide prevention methods. So this particular training it's called QPR, which stands for Question, Persuade, and Refer. And it trained that itself, that acronym QPR, it explains to people how exactly do you intervene in a suicidal crisis. So it trains people on how to ask the question, are you thinking about suicide, or are you thinking about hurting yourself? P is persuade, so persuading them to get help. And the R is refer, so how to effectively make a referral. So we've trained teachers in this intervention, and again, I said I'll present on it another time, but it proved to be very effective in changing attitudes about suicide and increasing knowledge about suicide, because there's a lot of misinformation. I think another thing I want to share, though, is what it was like to work with the teachers, because there's, I'm focusing on youth in this presentation and what affects youth, but a lot of the teachers themselves they're under a lot of stress out here, because a lot of these teachers, especially I noticed the younger teachers who were like closer to that age, people in their younger early 20s are closer to that teenage age. They were very worried, they really want to, and they have a lot of care for students. They really want to help students. And they themselves are coming to work every day, like so stressed out, because they have to teach their curriculum and support students, and they don't know how to do it properly, and they have their own personal problems at home, and they're just like bottling it all up and hurting so much inside. So as much as we need to train our teachers, we need to support our teachers. We need to give them, mental health support. And I'll talk more about that. And, now we're kind of moving to government interventions as well, of what exactly is, what do our communities think is possible in terms of delivering mental health care. So, integrating mental health care into more community clinics, having more NGO outreach and on suicide prevention. But many people reported mistrust of the government. Of course, that could have to do with political affiliation. So there are, everyone has strong beliefs on which political party actually cares about me or not. But, hopefully we can come past that partisanship and see that mental health affects, mental illness affects everyone. But I think, yes, we should always advocate and lobby for change in policy. I think that's very important. And on the other hand, there's so many things we can do as individuals to change things and to change the world. And we can't overlook that. So what I heard from people when I was doing this study was really what would help things and what would primary prevention, right? Catching people even before the problem starts is changing things in our culture. So a lot of things I discussed today had to do with shame and how there can be this culture of shame where people are so afraid to share what is inside of them because they're so afraid of judgment. And if we can learn to talk to each other with a lot more care and understanding and seeing things from other people's point of view, it will just change so much in the world. So that means if you're speaking to another person, recognizing your own feelings that are coming up is the first step. Recognizing when you have a trigger. And what I mean by that, I'll just give an example, is so let's say I have a friend and every time I compliment her, I notice she doesn't say thank you. Most people in this situation, they will either ignore it or they might confront the friend, right? They might say, why don't you ever say thank you? It's like you're such an ungrateful person. I'm your friend. Why don't you ever say thank you when I compliment you? Okay, so my friend might have a lot of reasons that she is not saying thank you. She might have low self-esteem, so she doesn't believe it. If I tell her she's beautiful, she doesn't believe it. Maybe she has low self-esteem. Second is maybe she doesn't even realize she's not saying thank you. Third is maybe she doesn't like it when I compliment her. There's so many reasons she might not say thank you, and that's kind of her own business. I have to let her handle that. But what I can share is what has been triggered in me. So when somebody doesn't accept my compliment, it makes me feel unseen. It makes me feel unnoticed. It makes me feel like I don't matter. And you can share that with your friend in that way, that, when you don't accept my compliment, it makes me feel like what I say doesn't matter. And I'm just letting you now you can do with that what you would want. I share that information with you. You can do with that information what you will. But this is a vulnerable spot for me. It's like a trigger point. It doesn't make me feel good. You don't have to tell people what to do or how to be. You let them be them and you let yourself be you. This is a very radical change in communication and how we deal with people in our culture, because we come from this culture, and I'm not just saying only Guyanese or Caribbean people. I think this is a worldwide thing, but this culture of communication of blame and expecting people to change for us. That you have to be this certain way because I want you to be that way. And it starts with our parents, right? The way we're growing up to meet other people's expectations and have no understanding of what we want for ourselves, or very little understanding of what we want outside of other people's expectations for us. So these changes and how we communicate our feelings and how we project feelings onto other people are what actually is going to produce change in our communities. Yes, of course, we need more mental health workers. Yes, of course, we need more support in schools. But really what the young people were communicating in the study is, I want to be heard and I want to know that I matter. I want to know that my feelings matter. And that can be a change that we make on a day-to-day basis in our interactions with people. Okay, so consistent with previous research on barriers to mental health seeking, we saw that there is limited awareness of services. There are negative beliefs about mental health workers, so there needs to be some education about that, public health education about it. And there is a big role of stigma and shame. What was emphasized were specifically what might be barriers for Guyanese youth. That, this is new info we didn't necessarily have before. This fear of a threat or punishment or abuse from adults, and a fear of betraying your parents for disclosure of suicidality to people outside of the family. So if I tell another adult I'm struggling, I'm betraying my mom, That's a big burden to put on a young person. And so the implications are that we should do our best to reduce the stigma of mental health and seeking mental health services. I do this every day. I really don't care. I tell people I've been to therapy since maybe the past 12 years I've been in therapy. Now I go to therapy twice a week. I go to therapy not because I'm struggling with, severe mental health issues, but because it helps me understand myself. And yeah, there are days that I feel pretty depressed, just like everyone else. There are days that, I know some of you who probably feel very depressed some days, feel very angry some days, feel your emotions can feel intense, or you feel very numb to your emotions. I'm not afraid to admit it, just like I'm not afraid to admit I got the flu shot. And I went to, my primary care doctor for a checkup 2 months ago. There's really no shame in it. And I think we should all talk openly about these things, because if we don't, then people will treat it like it's a secret. And also, especially as I know a lot of you here are healthcare workers, at least there is this understanding in the psychological community, but like they say, if you're going to be doing psychoanalysis, you need to be in psychoanalysis. Similarly, I don't think anyone would want to see a medical doctor who'd never been to the doctor themselves. So I think if you're looking to work in the area of mental health, you really should consider in some way seeking therapy. Although I know it's very easy for me to say that in New York, but if it's possible for you to seek counseling, try it out. I think it's important. Improving mental health literacy for people. So I think these basic things can be taught in, religious leaders or community settings. We can talk to people about how do you speak to your kids? What are communication styles in relationships? How do you express your care for other people? These are questions we can have. You don't need to be an expert to have these conversations, right? So improving mental health literacy and actually introducing that language of, people should know what is emotional intelligence. People should know what is emotional suppression. You don't have to use these big words, but, you can say, instead of suppression, pushing down your feelings or hiding your feelings. We know what those words mean. Increasing access, of course, and developing healthy parent-child communication. So that work I do on healthy parent-child communication, I've done mostly in the US, but I really hope to expand it in Guyana. If there's anyone who has a group that they're working with in Guyana and would like to, have me, I'd really love to do that. But obviously we're in a pandemic right now, and it's kind of hard to travel, but please get in touch. Essentially what I'm saying is I want to work with more groups of people. So this is my contact information. You can reach out to me here. I would really love to hear from any of you if you'd like to collaborate, if you have any questions or reactions, or you've reflected on anything and you'd like to share. I really love to hear from people. Oh, great. And I'm going to look at the chat. So we do have 12 minutes. So I have everyone's email address here. My presentation's at the end.
Dr. Persaud?
Yeah.
Persaud, thank you for that talk. Your talk was well received. The chat room was going crazy with just gratitude for your candor and explanation of your study. And very much so. We have people here in person in Guyana who have some questions in the audience, as well as there were 1 or 2 questions that came up in the chat. So do you have time?
I definitely have time. I think I can quickly answer the ones in the chat first, and then I'll ask the audience first. Then I'll ask the audience second. Okay, cool.
Okay, go ahead.
So, okay, someone asked for my contact information, which is up on the screen now. Maritza says, I was going to ask a question, but the time is short. Maritza, you have time now if you'd like to ask. Shellen was asking about an email to this information. I can email you a copy of my research article that has all of this. So just if anyone who wants a copy of the articles, send me an email to my email address on the screen, and I'll get that to you. Okay, and anyone else who is interested in collaborating, just email me, please. Okay, so people in the audience in person, I'll take your questions now.
I have one first one because there's someone in the audience who also mentioned that music activities, arts, and crafts are one way to develop communication with adults in child protective care, with social workers and other types of healthcare workers in the social science field. You mentioned that one of your study findings were that in the education system, music and arts and crafts were solicited. Who specifically within the school system recommended that arts and crafts and music be integrated or better integrated? And can you expound a little bit on how that would help with suicide prevention in Guyana?
Sure. Well, it was mostly students who were saying that. There were maybe a couple of young teachers who, like, let's say their early 20s, who had just been out of school, who said that they found it helpful, but mostly students were really wanting more arts and music. The way that it can help with suicide prevention is to take a step back and to understand more about suicide. What is at the core of suicide is a sense of hopelessness and feeling a lack of meaning in your life. So the opposite of that is to give people hope and to help them find meaning in their life. And so helping people understand specifically for you what gives your life meaning is also a way to help people not fall into a deep depression. So art, and it doesn't, so what I'm saying is, it's not like you specifically have to do an art project about depression. Like, that's not what I'm saying here. I mean, if you help people get in touch with what excites them and what gets them in connection with their joy, that is a way to prevent suicide. So again, you don't have to necessarily be writing a music piece or singing a song about being happy. It's about connecting people with what feels joyous to them. So that means you have to give them opportunities to explore it. There's young people I speak to and I ask, what makes your life exciting? And they're like, well, I don't know, because I've never had I think it could be painting, but I've never been given a paintbrush, so I don't know. So giving young people a chance to explore as many different things as they can, whether that is painting, athletics, all different types of sports, all different types of music, whether that's classical music or folk music or pop music or whatever it is, as much as we can. And we don't have to, it doesn't have to cost a lot of money. If one person has a YouTube account and they can play music for kids and let them have a 10-minute dance party, by themselves, and, just like have fun and be silly, like that adds a lot of meaning to a child's life. It doesn't have to be.
Was that missing when you were collecting your data here?
Did I find that it was missing in the lives of children? Yeah, it was. A lot of students felt that the pressure was so much on academics. And they were like always like studying and like trying to meet adults' expectations all the time. It wasn't that they had no time to play, but they felt like it still wasn't enough. Like they could have had more time to explore those other things.
Thank you. And how can we better support teachers here? From your research findings, how can we better support teachers in Guyana?
Yeah, so I understand that sending every teacher to one-on-one therapy is not going to be feasible, but if we could have some sort of support groups within schools that are run, there's like peer-led support groups, which you can like do trainings on online of how to like facilitate that. Again, you don't necessarily need to be a mental health professional, but having groups within schools where teachers can meet and actually talk about what's on their minds, and giving teachers chances to have a social life. So, I understand not every teacher is going to want to share about their personal life in front of other people, but we need to give adults chances to have friendships, adult friendships. You need to have those peer connections. And some of these teachers feel so overworked that they literally don't have a chance for a personal life. So we need to give them a chance to have a personal life, but also to have their own friendships, because that's essentially what supports your mental health, outside of your work. You have your own life.
Thank you. Any questions in the audience?
Yeah.
Make one moment.
Hi.
Can you hear her?
Yes, I can.
Hi, I actually graduated from Fordham, so it's nice to see a fellow Fordham person.
Nice, nice.
So I had a question about, you mentioned some of the trainings that you did with teachers to help them deal with mental health issues that kids are bringing to school. So I know in a lot of communities, religious leaders, like you mentioned, are people that individuals go to when they have issues. So have you ever considered doing training for them, similar to what you did with teachers?
Yes, I did with a small group of, I guess, young faith leaders in New York City in the Guyanese community, and it was really well received. So I'd really love to expand on that. It was really good.
Yeah, I was thinking about that when you were presenting it. I thought it would be an interesting
That's definitely one of my next steps.
Wonderful, thank you.
Thank you.
So I have some thoughts. Since I've been here at the Guyana Wellbeing Conference this week, Dr. Persaud, I've also heard about that kind of lack of professional exchange, being able, professionals having a safe space among each other to talk about maybe strategy, the way that they're coping with the stresses of their work. And it seems like even in primary care medicine here, within Georgetown Public Hospital here, among social workers here, that there was little opportunity for them to exchange with one with another. Instead, they introduced me to talking name. They said that people talk name here, and that because of that, people might not open up one with another, even among professionals. Can you offer us any insight on what recommendations you might have from doing your work with teachers and through the Ministry of Education, or any thoughts about how to reduce talking name and increase more of like a professional network where that could hopefully buffer some of the stressors that people in the workplace are facing here in Guyana?
Sure. So in the world of psychology, that's what we call supervision. So supervision in psychology does not mean literally having someone watching your work. Supervision, we have what's called peer supervision and individual supervision. So peer supervision time is when me and my other colleagues who are psychologists, we get together 1 hour a week and we talk about whatever is on our mind with our clients or with our work. And we're all at the same level. So our clinic director is not there. So the person who's above us is not there, and none of our trainees are there. It's just all of us who are on like the same level. And we can talk, we have that time where we can talk about, our clinic director annoyed us this week. My trainees are really giving me a lot of trouble, or I'm really struggling a lot with this patient. Can you guys please help me? I'm struggling a lot with this trainee. I need some support. So that's called supervision, peer supervision, and individual supervision means when you have supervision with your direct supervisor. And again, that time is used to process your emotions. Yes, sometimes in that time, I do go over a case like, I have this client who is, struggling with suicide, and I tell my supervisor and we work out a plan. But most of that time, I'm talking about my emotional reactions to my patients. So I will share things like, I had a client today who went through a really similar relationship problem that I did 3 years ago, and it brought up some feelings in me, and this is what happened. So having that kind of what's called individual supervision or peer supervision is so important, because you need to be able to share these things with your coworkers. That said, I think we need to understand our professional boundaries, which is that as much as I might tell my supervisor something like, yes, this client reminded me of a relationship I had 3 years ago, I don't need to go into details about, well, because this person broke up with me and this is why, and I hate them for that. They don't have to know all the details of my personal life, but letting them know this is a stressor that happened to me and this is why. And also that we don't have to be friends after this. I think a lot of the time in some of these institutions we work in, it's hard to toe that line between letting other people know I have a lot of stress on my mind and I'm having family problems, versus now this person has to be my friend, or they need to be involved in my life or helping me fix my problems. They don't have to. No, they can be your coworker. So I think being more clear about professional boundaries in the workplace would help, which is that, yes, it's okay to have our coworkers know about each other's lives. And also, if you're gossiping and talking people name, like clearly you have your own issues that you're running away from and not dealing with. If you're so focused on other people, it's because you're afraid of dealing with something in yourself. So if you find yourself talking name a lot, I don't understand, why don't you talk your own name? You know, like what's going on in your own mind? And also, like, you know, but also knowing that you don't have to over involve people if you don't want to.
Thank you so much for that. Last question, any insights on what, I mean, that's so helpful, what peer-to-peer supervision would look like in Guyana? Any thoughts about that? What individual supervision would look like in Guyana, and what that boundary setting would look like in Guyana, just based off of your own work?
Sure. I'm sorry, just 1 second. I just wanted to put up my Instagram too, because I have a professional Instagram and people want to communicate with me there. It's Dr. Samosa. Okay, so it's up on the screen now. Well, what peer supervision would look like is exactly
culturally adapted to Guyana.
Yeah, culturally adapted to Guyana. I think that it could work here, because when I was having those focus groups with teachers, some of them, or even when I was doing those trainings with teachers, near the end of it, I noticed it was kind of turning into peer supervision anyway, because they were being able to, they were seeking support from each other, and they were like, wow, I didn't know you were going through this. Like, thank you for sharing that. Or, oh, I didn't know, I knew that student was always really troubled, but I didn't realize that much, you know? So they naturally supported each other. But I think what it would look like in Guyana is either letting people form those groups themselves, or having much smaller groups. So here in America, you know, there's not, I don't know if there's so much an emphasis on the size of the group, but I noticed in Guyana that having like 5 people was enough, where people could like open up and notice if another person is not talking, but it didn't feel like, okay, 10 people in a room just like yapping about their life, like, and there was not so much focus. So I would say keep the group on the smaller side, let people self-select, don't make it mandatory. But encourage people, like, and bring people in essentially. So if you think someone could benefit from it, but they're not coming, don't be afraid to tell them, hey, I'm going to this supervision meeting. It could be very helpful. I think you should come. And again, making sure that like only people of the same hierarchy level are meeting in those meetings. And it's not like your director is like, okay, give me notes about the meeting afterward. Like, it shouldn't work like that. People should be able to have that private time.
Thank you. Thank you. I know that's our last question here, but I do have a question from one of our panelists earlier. What is your insight on a person being less judgmental when it comes to mental health in Guyana?
So like how a person can become less judgmental?
Yeah, the beginning of your presentation focused a lot on shame and judgment and hiding as a result of that. And you sort of touched on it being cultural when talking about mental health issues. So I'm supposing that the person is asking, what are ways that we can address that, and specific to Guyana, culturally adapted to Guyana?
So I think it's also about again, being more open. Like just now when I was able to tell you all, yeah, I go to therapy, being more open with each other and in a way that feels comfortable to you. So for example, my dad, I'll notice when he's talking to his friends, you know, he's an older Guyanese man. He doesn't have the language to say depression per se. Like, I mean, he knows what the word means, but I don't know if he's good. I don't know. I don't see him using that in kind of colloquial speech, but he might tell his friend, you know, I just like, I'm feeling really tired nowadays or something. So people already do have a language of talking about mental health. But I think one way to combat the judgment is to be able, in those moments where some, like, basically catch people in the moment. So if my dad were to tell his friend, hey, I'm just feeling so tired these days, like, I just like, I'm sleeping a lot. If his friend were to say, like, oh, well, you just need to play cricket with us more, like, that's a little bit invalidating, right? So we have to kind of train ourselves into recognizing invalidation when someone is, even if they have a very good intention, to be able to notice when you're not just listening. So if you have an impulse when someone shares something that's related to mental health, to just be like, oh, no, but it's okay, and like cover it up, change it to tell me more about that. So I think the cultural change comes from those little changes in communication. Tell me more. How did that feel for you? And reflecting feelings back to each other. Well, that sounds like it was pretty hard for you. I could probably give a whole presentation on communication and how we can change it. But I think when it comes to judgment, we have to call it out when we see it. And that doesn't mean shaming someone in front of a whole group. Like, you don't have to tell, if your mom is being judgmental, you don't have to like say it in front of the whole family, but you can pull your mom aside and be like, Mom, the way you were talking about the next door neighbor's daughter, I didn't really like it because she's such a good girl, she's a good girl, and I think she was struggling a lot, and maybe we need to have some understanding, like try to be understanding of, you're not telling your mom she's a bad person, but just encouraging more care and compassion, and wherever you see it, calling it out.
Oh, thank you for this. This is such a rich presentation, Dr. Persaud. It's always a pleasure. Think of Dr. Henry Cloud, who's a famous psychologist in the States, and he said that bonded relationships is what produces meaning, and you touched on that. You also said we need more boundaries in our professional settings, and boundaried relationships give satisfaction. Exactly. And we need more of that. And also competency is what builds purpose, and we need more skill building, and you touched on that. So thank you so much for bringing such a rich discussion about mental health specifically here in Guyana and sharing with us your study. We hope to continue contact. Please feel free to reach out to Dr. Persaud